Hello, everyone, and welcome to today's broadcast, Cardiovascular Disease, Applying MRI to Study Atherosclerosis, the Aortic Arch, and Endothelial Permeability in Small Animal Models, presented by Dr. Claudia Calcagno. I'm Christy Jewell of Labroots, and I'll be producing today's event. Today's educational web seminar is brought to you by Labroots and sponsored by Bruker. Bruker enables scientists to make breakthrough discoveries and develop new applications that improve the quality of human life. Bruker's high-performance scientific instruments and high-value analytical and diagnostic solutions enable scientists to explore life and materials at molecular, cellular, and microscopic levels. For more information, please visit bruker.com. This presentation I'm about to show you was broadcast live earlier today, but I would like to remind everyone that this event is interactive. You may submit questions at any time you like during this presentation. Questions may also be submitted during the on-demand period, and we encourage you to participate. To do so, simply type your questions into the Ask a Question box and click on the Send button. Your questions will be addressed by the speaker via the contact information you provided at the time of registration. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Ask a Question box located on the far left of your screen. Lastly, at the end of the presentation, you will receive a poll which we kindly ask you to complete. Your answers and suggestions will help improve our webinar program, and it is greatly appreciated. Our moderator today will be Todd Sasser, the head of Bruker Preclinical Imaging Applications. It is now time to enter the topic of the day. Todd, over to you.
Thank you, Christy, for a nice introduction, and thank you, everyone, for joining us today. Our webinar today, titled Cardiovascular Disease, Applying MR to Study Atherosclerosis, Aortic Arch, and Endothelial Permeability in Small Animal Models, is presented by Dr. Claudia Calcagno. Dr. Claudia Calcagno holds an MD from the University of Genova and a PhD from the Icahn School of Medicine at Mount Sinai. Her main research interest is dynamic contrast enhanced MRI of atherosclerosis arterial vessel wall. Dr. Calcagno, you may begin your presentation.
Thank you so much, Todd, for the nice introduction. As Todd mentioned, I will be talking about application of MRI to study atherosclerosis, that means cardiovascular disease, with specific focus on the quantification of endothelial permeability in small animal models, in this case, atherosclerotic mice. So first of all, I just wanted to give you a little bit of background on why we would like to study cardiovascular disease. So as you can see from the graph in this slide, cardiovascular disease due to atherosclerosis is actually the main cause of morbidity and mortality worldwide, and that holds pretty much for all age groups. And it surpasses even cancer in all age groups. And there is definitely a diagnostic and therapeutic gap in cardiovascular disease. Even individuals that are treated aggressively with standard of care, optimized lipid-lowering strategies such as statins that you may have heard of, still have a very high residual cardiovascular risk. And there are actually some individuals that whose risk cannot be adequately captured by population-based risk scores. So our goal, and the goal of many other researchers in the field, is to develop non-invasive quantitative measures to better quantify cardiovascular risk in these patients and to better stratify them and better treat them and diagnose them. In doing so, many people have been focused on trying to diagnose basically what are called so-called vulnerable atherosclerotic plaques, to try to identify these plaques. Vulnerable atherosclerotic plaques are plaques at a high risk for causing severe acute clinical events. That would be, for example, heart attack and stroke. And they have very well-defined histological characteristics Among these, the most salient that we will sort of discuss in this talk are the presence of inflammation and the related presence of leaky microvessels and endothelial, and so enhanced endothelial permeability in the plaque. So you can see, for example, in this figure, a schematic of the progression of atherosclerosis. And you can see that, for example, an increased endothelial permeability and endothelial dysfunction, a disrupted endothelial barrier actually allow for the initial lipid accumulation in plaques. Later on, increased endothelial permeability, an extensive network of microvessels or neovessels that form in the plaque facilitate actually the extravasation of inflammatory cells that you can see here in the middle that are basically recruited after the maladaptive inflammatory response that is triggered by lipid accumulation itself. So as I mentioned, we would like to develop quantitative measures of these histological correlates that would allow us to identify and characterize vulnerable high-risk atherosclerotic plaques in vivo and non-invasively in patients. Focusing specifically on endothelial permeability, there are several ways that this parameter can be quantified and investigated using magnetic resonance imaging, which is the focus of our talk. Most methods that are used in atherosclerosis are based on contrast agent injections, so the use of contrast-enhanced MRI. In our case, this entails the injection of T1 shortening gadolinium-based contrast agents. One possible strategy for quantifying endothelial permeability is the one that I show here in this slide. Typically, one image at time 0 before contrast agent injection is taken. You can see one example here of an image taken before contrast agent injection in an atherosclerotic rabbit where you really don't see any enhancement. And then contrast agent is injected. A certain amount of time typically passes, and then the same exact image is taken after contrast agent injection at time t. That has to be predefined by the researchers and may vary depending on the animal model or the vascular territory that is studied. You can see in this case, after a certain amount of time, the images look a lot brighter, which means the contrast agent has extravasated in certain tissues. You can see, for example, at the bottom right corner, a zoomed-in image of the rabbit abdominal aorta that looks a lot brighter with respect to the pre-contrast image. And I'm just exemplifying, this process here in this schematic. You can see here in gray some extravascular extracellular space in a tissue. These white ellipses are actually cells. The red dots are microvessels in the tissue, and the bigger red line in the middle is a feeding vessel of the tissue. You can see that the left side of the tissues are represented with a dashed line. The endothelium in this case, it's permeable, while the right side is not permeable. And in the schematics after contrast, you can see these small black dots representing the contrast agent in the vessel lumen extravasating in the tissue, and also present in the inside capillaries in the tissues, but not in cells, because these contrast agents that we're talking about today are actually extracellular. So basically, that is the basics of the process. And contrast agent uptake can be really identified measured in a couple of different ways. We can simply look at signal enhancement, which is basically what I mentioned before, the signal getting brighter. after the injection of contrast with respect to before contrast agent injection that you can find here in these schematics. Another way to measure contrast agent uptake is to actually quantitatively measure changes in T1 relaxation time that are caused by contrast agent injection. In this case, because these agents are T1 shortening agent, we're going to be looking at a shortening in T1 at a certain time T after injection, as it's schematically depicted here. And these, however, are not the only ways that we can capture contrast agent uptake in the tissue. Instead of simply imaging at time T0, waiting, and then imaging after contrast at a certain time predefined T, we can keep on acquiring images before, during, and after the injection of a contrast agent. And as depicted here, we can follow the kinetics of uptake of the contrast agent in the tissue. And this is depicted in a similar schematic representation that you saw in the previous slide, where you can see that, for example, in the pre-contrast schematics, there is no contrast agent on the left side in the permeable tissue. Immediately after or during contrast agent injection, a few contrast agent particles sort of permeate the tissue, and more until we reach time T. This approach is called dynamic contrast enhanced MR. So it's an approach that allows measuring the uptake curve of contrast agent in a tissue of interest. And this is particularly useful to try to calculate more quantitative parameters that are related, for example, as you can see in this box, to tissue permeability, to the fractional plasma volume in the tissue, and that would be basically the amount of red dots that you have, which would be small vessels in each tissue, or, for example, the backflow from the tissue to the plasma compartment, and the amount of extravascular, extracellular space itself in the tissue, which is depicted here in gray. That would be typically loose matrix or connective tissue, right? And if you were to look at an uptake curve of contrast agent in the tissue of interest over time, it would typically look like this, right? With concentration being, I would say, almost basically at zero before injection, and then rising more or less rapidly depending on the permeability of the tissue, plateauing, and then one step that I'm not showing here, sort of going down as the contrast agent flows back to the plasma compartment. So this kind of curve can be analyzed using modeling-based approaches, which is kind of somewhat what I described before, but also non-model-based parameters such as the area under the curve, for example. The uptake slope would be entailing taking the slope, for example, from here to here, or the time to reach peak concentration. So going specifically to atherosclerosis, a lot of work has actually been done to develop quantitative MR-based measures of endothelial permeability in atherosclerosis. And I am listing here only 3 review papers that are more, obviously, that constitute a good starting point, I think, for a literature search on this topic. A lot of work has been done actually in human patients with cardiovascular disease, especially in the carotids, also looking at histological validations when these specimens were taken out for carotid endarterectomy that was, of course, performed as standard of care intervention. But also a lot of studies are focused on animals, for example, in atherosclerotic rabbits and in mice. In this talk, I will specifically focus on some studies and some techniques that we are developing to study endothelial permeability in mice. So first of all, why would it be important to develop these techniques in mice? there are several reasons. One is that mice can be obviously genetically manipulated, I wouldn't say easily, but probably in an easier way than other bigger animals, to create several disease models, right? There are, for example, mice that are atherosclerotic prone, but also diabetes prone, so that can be interesting to study. And they are a well-characterized model of atherosclerosis, and actually more than one mouse model of atherosclerosis exists. They can be used in large-scale studies because even genetically modified mice are fairly affordable in that sense, so definitely more than larger animals. They can be investigated using sophisticated genetic, cellular, and molecular assays that are not so easily available in larger animals, either because of cost reasons or simply because they've not been fully developed yet. This is interesting to us because these assays can be a very good complement to in vivo imaging, either to tell us, something more about what we're looking at with in vivo imaging, or just as a ex vivo validation or to better understand the disease process. So in the mouse specifically, we've been focusing on studying the aortic root, which you can see here highlighted in ApoE mice and in wild-type B6 mice. The reason behind choosing the aortic root as a vascular territory to study is that plaques develop very reliably in this territory. They're typically quite permeable, as you can see here, by the enhancement and extravasation of contrast agent in a fluorescence image in this case. And plaques in this territory are quite inflamed, so they serve our purpose very well. So there are challenges otherwise in imaging the mouse aortic root. For example, you can see here the aortic root is indicated by this red arrow coming out, of course, of the left ventricle. And as you can imagine, the aortic root moves constantly with the cardiac and respiratory cycle. It's a structure that, especially in the mouse, is very small in size. And so we're talking about taking images of a structure that is very small and constantly moves. And we all know that typically in MRI, this is very challenging and requires a synchronization of imaging with the cardiac and respiratory cycle. So the conventional strategy using approaches that are triggered by electrocardiogram signal, where you would put actually electrode in a patient or a mouse, would be to image and acquire basically a portion of the image, a portion of K-space lines during a period of time when the heart is fairly stationary, so that no motion artifacts may contaminate the images. However, in mice, the additional problem, so to speak, is that the heart rate is really, really fast. I'm indicating here 300-400 beats per minute. This may vary, of course, and it may be a little slower when the mouse is under anesthesia, and it may vary a bit depending on how the anesthesia is performed. But in general, the heart rate won't go, I would say, down below 200 beats per minute. So, of course, the problem is to acquire very high resolution images, being able to acquire only a few K-space line per heartbeat. This takes many, many, many heartbeats, and so it's very slow. And this kind of imaging may not be suited to capture the fast kinetics of contrast agent entering plaques in the aortic root. So in order to overcome these obstacles, we have taken, and I'm showing here, pretty much the same concept where over different heartbeats, a different portion of K-space would be acquired, and then all of these will be combined together to obtain a full image of one cardiac phase, basically one snapshot that can be acquired either in systole or diastole. A slightly different approach can be taken, which can lead to more efficient imaging. And that would be, for example, to continuously acquire K-space lines regardless of basically the cardiac phase in which these are acquired. So K-space lines are acquired continuously and are synchronous with the beating heart. And then, and some of you may recognize this approach also from clinical MR imaging, K-space lines can be binned into specific cardiac phases depending on the signal from, for example, ECG electrodes that may be in the mouse or in the patient, right? To form different images of different phases of the heart. So you would see the heart moving across those. However, you know, the ECG itself, especially for such an approach where K lines are acquired continuously and gradients are basically working almost constantly, I would say, ECG approaches in mice at high field, as we're using, are not very effective because the gradients from the magnet themselves create currents in the heart that distort the ECG signal. So it's very useful in these small mouse models to actually use self-gated approaches, which I will go into in a minute. And in this case, binning is basically based on a navigator signal that captures the cardiac and respiratory cycle and doesn't need the use of any external devices such as ECG electrodes. And I'm illustrating this concept in a little more detail here, where you can see, in this case, applied to cardiac imaging and not to vascular imaging of the aortic root, you can see a navigator slice that is placed actually at the base of the heart, where cardiac motion can be detected, but also respiratory motion, of course, from the lungs and the thorax, and an imaging stack that is put on the ventricle in this case. The navigator slice is played before every excitation, as you can see here in the pulse sequence diagram. And so it's a 1D signal that, as you can see in this following slide, looks like this after it's acquired. And that can be deconvolved pretty much in a weighted respiratory signal that you can see here, which is, of course, slower and corresponds to these deeper downward peaks, and in a weighted cardiac signal, which is, of course, much faster and corresponds to these faster peaks. And then typically what happens is that K-space lines that are acquired across many cardiac cycles can be binned according to the cardiac signal that is acquired by the navigator. To acquire full images, of course, of different cardiac phases, the approach is to acquire the full K-space matrix many, many times over many, many heartbeats, and until a sufficient number of K lines to fill each cardiac phase has been acquired. And the fact that there is no heartbeat that is exactly the same as the previous one or the next one in terms of length, there is always a bit of variability, ensures that it is going to be very unlikely that the same lines keep on being acquired over and over again in the same phase of the cardiac cycle. So this is an intrinsic pseudo-random filling that basically ensures that after a certain number of cardiac cycles, full images will be acquired of all these phases. And now I'm going to show you a few examples of how we have actually applied this method to acquire quantitative images of endothelial permeability in the mouse aortic root. I'm showing here a few examples of what I would call almost a two-chamber view, not really, because you can see here the aortic root and not the mitral valve, but of the left ventricle. You can see here the left ventricle, the aorta branching out of it, and the aortic root here. You can see a four-chamber view of a mouse heart. You can see the left ventricle, again the aorta, the aortic root right here, and the right ventricle here. From these images, we can actually plan axial slices right through the aortic root, which you can see here. That's basically this circle here in the middle. And one thing that I should mention that I've not mentioned before, and this is very specific to vascular imaging, typically when we perform vascular imaging, we use so-called black blot techniques if we want to, of course, see the arterial vessel wall and not the vessel lumen. These are specific MRI techniques that null the signal from the blood pulse so that the vessel wall can be easily seen. And interestingly, in our case, and as it has been demonstrated before, we can use the same navigator that we use to Bimke space to actually also obtain a black blot signal by simply varying the the flip angle of the navigator, which is what we actually do here, where we obtain bright blood images with a certain flip angle of the navigator and black blood images of the root. In fact, you can see in this case the middle of the root is black, and you can faintly see the vessel wall of the root in this black blood image pre-contrast, and you can see delineated a little better after contrast. So we have used this approach in several flavors, I would say, to quantify endothelial permeability in this territory. One of the approaches that we have used, which I mentioned before, is actually mapping of a decrease in the T1 relaxation time after contrast agent injection. We have taken an approach that was actually published in NMR and Biomedicine in 2016 to look at permeability in the mouse myocardium, and we just adapted it to the mouse aortic root. And this approach consists basically in acquiring a pre-contrast T1 map using 3D imaging with variable flip angles, injecting contrast agent, and then following the uptake of contrast agent in the aortic root using acquisitions with only one flip angle. And based on these equations that I'm showing here, you're going to be able to basically calculate T1 at each point in time after contrast agent injection and get an estimate of the decrease in T1 and therefore endothelial permeability in this territory. I'm showing here examples of some images acquired pre-contrast and after contrast. You can see this is the images from the T1 map that was acquired pre-contrast with, as you can see, different flip angles. So basically these images are put together, and based on the signal equation of the specific sequence, the pre-contrast T1 relaxation time can be calculated. These are images instead acquired after contrast agent injection. You can see, in fact, the root indicated by the yellow arrow enhancing, getting brighter, and actually you can see even the enhancement decreasing a little bit as time goes by because of contrast agent washout from the root. So by basically normalization of the signal of each one of these images to the previous one, we can calculate T1 post-contrast. You can see here some preliminary results actually from these data that were presented this year at the ISMRM meeting in Paris. You can see that simply looking at signal to noise before and after contrast doesn't really lead to a meaningful difference between young and old mice. This is what the two bars represent. You can see that between young and old mice, the T1 pre-contrast is basically the same. In this case, I'm actually mentioning it as R1, which is 1 divided by T1. So if T1, of course, decreases after contrast, 1 divided by T1 would increase, and this is sometimes a measure that is used because it's just simpler, I would say, to talk about and understand. But you can see that the R1 post-contrast is higher in older mice with respect to younger mice. Conversely, of course, the T1 would be lower. This indicates higher extravasation of contrast agent in older mice with respect to young mice, so higher endothelial permeability. And so is the ratio of the R1 between post and pre-contrast, which basically, again, indicates higher permeability in the older mice. So if you recall, during the introduction, I said that, however, this is not just the only way to calculate endothelial permeability. We can also use what we call dynamic contrast enhanced MRI to try and follow more closely with higher time resolution the contrast agent uptake curve in the tissue of interest. So in this case, our acquisition is basically the same, but we reconstruct it a little differently. So we could continue to acquire constantly the same K-space matrix over time, over many, many cardiac cycles to obtain, as I said before, different cine images of the heart in different phases and of the root. But during this acquisition, and in this case the acquisition would have to be very long, maybe half an hour or more, we also inject a T1 shortening contrast agent. So if we were to reconstruct images from this kind of acquisition, basically images acquired before the injection of contrast would look like as if there was no enhancement, which is what it should be. But as we inject and as we reconstruct images not only being by cardiac phase but also over time, we would see uptake of contrast agent. So this is an approach that we have actually used to start developing a dynamic contrast enhanced MRI of the mouse aortic root. I'm showing here a couple of examples of different kind of reconstructions that can be performed from such an acquisition. Typically, this leads to a lot of flexibility in terms of the number of cardiac phases that can be reconstructed and the number of temporal dynamic frames that can be reconstructed. I'm showing here an example of images acquired with 8 cardiac phases and only 4 temporal dynamic frames. You can see here a first image acquired before contrast and then 3 images acquired after contrast. In this case, the acquisition was about 32 minutes. So basically each one of these temporal dynamic frames comes from 8 minutes of acquisition. So of course this impacts the signal to noise of the images. You can see here, although of course it's a lot smaller, the same exact acquisition that is however reconstructed with 8 cardiac phases, so same number of cine images in the heart, but 12 temporal dynamic frames. So you can see in this case 3 pre-contrast images, and while the other images are post-contrast. Clearly in this case slightly lower signal to noise, because of course the time that is allotted for each one of these images is less than it was before. And we could go on and on. I have another example with always 8 cardiac phases but 20 temporal dynamic frames. So these are just some examples here. And now I would like to show you some videos, actually. So I'm going to go ahead and show you the first video, where basically I am showing one cardiac phase over basically the uptake of contrast enhancement. You can see in this case, this is an example with 20 dynamic frames. It's about, the acquisition was still about 32 minutes, so we're about 1.5 minutes per temporal dynamic, which overall would be considered pretty slow, but you know, for imaging dynamically, the mouse aortic root is quite acceptable. And I'm going to go ahead and show you another video instead of just one temporal frame acquired after contrast agent injection. In this case, the temporal frame is the same, the snapshot after contrast is the same, but I'm showing you here the cine images of the aortic root cycling through the different cardiac phases. And in fact, you can see the aortic root moving in this video, while you wouldn't see it moving or moving very little in the video that I showed before. Lastly, I'm showing you here an example of dynamic curves obtained from several mice in the aortic root, obtained with this approach that I just described, compared to skeletal muscle, which is also in the field of view. Skeletal muscle, as an aside, is a tissue that has typically very low permeability, and in many cases is taken as some sort of reference tissue. And you can clearly see that overall enhancement in the aortic root is much higher than the skeletal muscle, indicating higher permeability in this territory with respect to muscle. With this example, I would like to conclude, and I'm open to taking any questions you may have.
Okay, thank you, Dr. Calcagno, for your informative presentation. So if the audience has a question you'd like to ask, please do so now. Just click on the Answer a Question box located on the far left of your screen, and we'll answer as many questions as we have time for. So let's get started. Our first question is, are there any possibilities for acceleration?
So thank you. This is actually an excellent question. The answer is yes. There are possibilities for acceleration in the approach that I described before, this self-gated approach. So if you recall, when I described the self-gated imaging of the aortic root, I said that the acquisition of K-space line happens continuously, and the acquisition is intrinsically random, so to speak. By that, I mean that there is, as I said before, the chance that the same K-space lines will be acquired in the same exact cardiac phase during different cardiac cycles is very low. And that is due to the fact that different cardiac cycles typically differ in length very slightly, but enough to make this process sort of intrinsically pseudo-random. And these kind of acquisitions are perfectly suited for compressed sensing reconstruction. This is actually an approach that has been applied by our collaborators in Amsterdam to obtain very fast cine images of the myocardium accelerated, if I'm not mistaken, up to 90 times with respect to what you could obtain without acceleration, and also using even ultra-short TE radial sequences. for improved scene imaging with less flow artifacts of the heart. So yes, this is a possibility.
Okay, another question here. Are there any other vascular territories in the mouse where it is useful to evaluate endothelial permeability?
Thank you, yes. So there is actually work has been done also in the brachiocephalic artery of the mouse. This is another vascular territory where plaques develop quite consistently in mouse models, and they are actually quite inflamed. And therefore, this has been applied also, the investigation of endothelial permeability has been applied also in these cases. I have to say most of these approaches actually have used slightly different techniques than the ones that I have described, based on Luke Locker acquisitions actually for quantitative T1 mapping, and slightly different contrast agents. The contrast agent that I have described here is extravascular, extracellular, and it's a small contrast agent, at least that's the one that we've used in the examples that I have shown, that doesn't bind to albumin. In other cases, other researchers have used some contrast agents that specifically bind to albumin and extravasate a bit slower than the one that I showed here. But a lot of work has been done in this area, also demonstrating how these measures are sensitive not only to plaque progression, but to aggravation of endothelial injury, either with wire injury, like mechanical injury, or by using endothelial toxins, such as the Russell Viper venom, but also sensitive to changes after therapeutic interventions, for example, with statins or minocycline. So yes, this is also an active area of the research.
Okay, another question. Has self-gated imaging been used for this application in other studies?
Yes, actually it has. And for application, that's another application actually to the brachiocephalic artery. There have been some studies there. But only using not dynamic contrast enhanced MR as I showed here, only using T1 mapping actually, with variable flip angle with a similar approach as I used, but only post-contrast and after a fixed amount of time that is suitable for imaging with, I believe, albumin binding agents. Okay,
so we have time for one more question. How can DCE data be analyzed?
So that's a good question. So I have mentioned some approaches before during the introduction. In general, DCE data, especially in cancer where the technique has been used extensively, are analyzed using modeling-based approaches. And if I can go back to the slide that we have on the background, I think it would be easier to show you. So you can see here one of the most used kinetic models that is actually employed typically to analyze DCE MRI data. You can see, as I mentioned before, several parameters can be evaluated from this model. This is called a modified Tufts model. The fractional plasma volume in the tissue of interest, VP, can be calculated. K-trans, which is typically a measure of flow permeability, can be calculated. And KEP, the backflow of contrast agent from the tissue to the plasma compartment, can also be typically calculated. As you can see, to perform kinetic modeling, one input, is required. That's called CP. That's the contrast agent concentration in the feeding vessel. That would be the sort of red stripe here in my schematics. But of course, in order to fit parameters, we also need an estimation of the concentration in the tissue of interest. That would be CT. So if you recall, I briefly mentioned that many applications for vessel wall imaging use black blood techniques that willingly suppress the signal from the blood plasma during acquisition so that we can better see the vessel wall. For practical purposes, for DCE MRI modeling, this means that CP, so an estimation of the contrast agent concentration of the blood plasma in the blood plasma, will not be available for these kind of studies because we don't have really signal from which to estimate it. So several other approaches can be taken to actually analyze these data specifically. As I mentioned here on the right side, we can calculate area under the curve after doing our best to convert MR signal to contrast agent concentration in the tissue, uptake slope, time to peak. And there is also some other approaches that are quite interesting. Those are called relative modeling approaches. And they try to extract relative kinetic parameters relative to other tissues, for example, using the muscle. If you recall, in the very last slide, I showed you muscle curves as an example. So, for example, these curves could be used as the basis for relative modeling to extract relative kinetic parameters of permeability in the aortic root. So I think those are the main options.
Thank you, Dr. Calcagno and Todd Sasser. Now, before we go, I would like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today will be addressed by the speaker via the contact information you provided at the time of registration. Additionally, a short poll will now pop up on your screen. Your feedback is important to us. Thank you for participating. I would like to again thank Dr. Claudia Calcagno and Todd Sasser for their time today. We would also like to thank Labroots and our sponsor, Bruker, for underwriting today's educational webcast. This webcast can be viewed on demand through March 2019. Labroots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. That's all for now. Thanks for joining us. Until next time. Goodbye.